Hello, everyone. My name is Lizzie Stewart. We are pleased that you all could join us for this week's lecture in Volume 10 of our No Neuropsychology Didactic series. It brings you lectures from experts in the field covering different topics each week. The series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to No Neuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lecture content. You can access these through our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box in the lower left of your screen, and a recording of today's lecture will be provided on our YouTube channel and website later this week. Now it is my pleasure to introduce Dr. Carla Rivera Figueroa and Dr. Michelle Miranda for today's lecture entitled Pre-Surgical Epilepsy Evaluations, including Cross-Cultural Evaluations. Dr. Carla Rivera Figueroa is a bilingual clinical psychologist originally from Puerto Rico. She earned her bachelor's degree in psychology from the University of Puerto Rico before relocating to the continental United States to pursue a PhD in clinical psychology at the University of Connecticut. She is currently a neuropsychology postdoctoral fellow at the University of Colorado Anschutz Medical Campus. Clinically, most of her work focuses on evaluating adult patients with various neurological conditions and conducting pre-surgical assessments for epilepsy and deep brain stimulation procedures. A key aspect of her clinical work also involves performing neuropsychological evaluations for Spanish-speaking patients, a role which she finds particularly rewarding. Driven by a commitment to addressing barriers to care for underserved populations, Dr. Rivera Figueroa aims to contribute a more inclusive and culturally responsive neuropsychology field, making this a central part of her professional mission. And Dr. Michelle Miranda is a bilingual, bicultural neuropsychologist at the University of Colorado Anschutz Medical Campus, where she serves as the Director of Diversity, Equity, and Inclusion for the Department of Neurosurgery. As a clinical assistant professor, she developed the first fully Spanish-speaking service in neuropsychology for adults and provides WADA testing for bilingual patients. Her career special interests include cross-cultural neuropsychology, culturally sensitive and equitable practices in healthcare, bilingualism in epilepsy, and WADA evaluations for non-English speakers. She is also passionate about the role of a provider and as an advocate and champion for social justice, and thus has provided several lectures and training on providing socially just and culturally sensitive neuropsychological evaluations, both nationally and internationally. And she facilitates uplifting the voices of patients within the medical team and beyond. So with that, I'll turn it over to Dr. Michelle Miranda and Dr. Carla Figueroa. Thank you.
Well, thank you for the introduction and thank you for the invitation. We're so happy and excited to be here. We're grateful for this platform. We know how big No Neuropsychology is. And so we're just so grateful to be a part of this. So thank you again, everyone, for being here, joining us. So let's get started.
Let me just figure out how to share my screen and then we'll get started here. All right. All right, can you all see that? Are you seeing the notes or the actual
Yeah, it's not in
presentation?
presenter view yet.
It's not, okay.
No.
Let me try again. Okay. See here. Is that better?
Yep.
Excellent. Figure it out. Yay.
All right. So let's get started. So we're going to start with just a very brief introduction, and then we'll go into what the role of the neuropsychologist is for these pre-surgical evaluations, and how to complete this in a more detailed way. And then we'll have how to present this information, some suggestions on how to present these information in surgical conferences. And then we'll finish off with a case study. So let's go ahead and start with the introduction piece. And for this part, it's really just for us to get a way of how to discuss this information with our patients in lay language. There is already a presentation on neuropsychology by Dr. Amanda Gooding, and it's a fantastic presentation with a lot of the basic terminology, definitions. And so really that presentation is kind of a good introduction for this. So I'm just going to briefly go over how I discuss seizures and epilepsy with patients. And so I talk about it as, our brain cells communicate through electrical impulses. That's normal. That's just how our brain works. But sometimes, for whatever reason, there's some abnormal activity that starts in the brain somewhere. And basically, there's some abnormal electrical activity that causes kind of like a little electrical storm in the brain. And it could either stay in one area where it could be focal, or it could include other parts of the brain. And so it could generalize. And so that's kind of how I explain it to patients so they understand kind of the biological underpinnings of seizures. And depending on where this electrical storm starts, there will be some very specific behaviors that can happen. And so when we talk about the origin of seizures, and these are the two most common types of epilepsies, but also seizures. So temporal lobe epilepsy is the most common type, with about 60% of people with epilepsy have a temporal lobe epilepsy. And these types of seizures that come from the temporal lobe are generally less frequent. They have a slower onset, a slower progression, but they also last longer. They could be a couple minutes long. They tend to start with an aura. They have automatisms. There's an initial kind of emotionless stare that happens, and it can impact speech depending on which hemisphere it starts. And then it's more likely to have some post-ictal confusion. The second most common type is frontal lobe epilepsy. And these types of seizures they happen more often. They're more abrupt and rapid. They have a shorter duration. They can be seconds long. And they can often arise from sleep. They can have some complex posturing or gesturing. They can come with some complex behavior. They can occur in clusters, and they have more tendency to generalize. And because they're of shorter duration, they can also have some minimal post-ictal confusion. And it's important to know about this because this is how we start talking about these things with patients and providing some education, which we'll talk about more in a little bit. But talking about these things in a lay language is important when you're talking with patients. And we'll see here in this next slide some more behaviors that are common during some seizures and after. So we'll go on here to really talk about the role of the neuropsychologist in these evaluations. So in neuropsychology, as with any referral that we get, our role is really similar to any other neurological condition where we have to answer a referral question, right? We establish a cognitive profile and we create a tailored treatment plan. What we do is we want to diagnose. We want to diagnose any neurological conditions, neurobehavioral, neurodevelopmental conditions, any psychological, psychiatric conditions that may exist. and really assessing adaptive functioning and how this can assist in some educational and even vocational planning, evaluating cognitive behavioral side effects of the medications, and monitoring changes over time. So this is our role. But then when we look at these surgical evaluations specifically, so the International League Against Epilepsy is an organization that is made up of experts in the field internationally. And they are the ones that really establish a lot of the guidelines that we use. And they have established guidelines for neuropsychology. And their guidelines are for us to establish a baseline against which we can change, we can see change over time, to provide a collaborative contribution to seizure characterization, lateralization, and localization. So we would play a role in providing information about seizures and in lateralization and localization. We would also provide evidence-based predictions of cognitive risk associated with the proposed surgery. And then to provide the evidence base for comprehensive preoperative counseling, including exploration of patient expectations of surgical treatment. And so this is what the ILAE guidelines are for neuropsychologists. And I think, this is kind of just a start for us, but I think we can offer so much more in our evaluations. So for these surgical evaluations, we get to gather information, and we get to gather a lot of information just because of the way that our evaluations are set up, where we get to spend a little bit more time with patients than our medical colleagues. And so we have this really rich opportunity to gather as much information about this whole human being, which we'll talk about in a little bit here. We also can diagnose and consider the impact of psychosocial adjustment. We can provide education to patients and advocacy for them. We can assist in lateralizing and localizing and getting this baseline assessment. We could also help predict cognitive outcomes of surgery and assessing some post-surgical cognitive and behavioral functioning. So we'll start here we'll go on to gathering some information here. And so this is kind of the first step of our evaluation, is we're looking at who these people are, right? Who our patients are as a whole being. It is important to have a really holistic view of our patients. And so this is our opportunity to do that. So first, we do a chart review. We look at what the medical history is, because that guides and informs our interview. We also want to know about our patients, and especially when we're seeing patients from other cultures, we want to have a working knowledge of the patient's culture. It's the same thing as doing an initial chart review where we want to get some medical information. We want some cultural information also, because this guides the questions that we asked during our interview. One tool to do this is to use ethnomed.org. It's a really great website that I really recommend, because it is actually specifically for providers, medical providers, healthcare providers, and it has a whole list of countries and cultures. You can go on there and, for example, find Mexico, and you can read about the culture and how it can affect some medical relationships. It even provides information about how to greet people when you go get them from the waiting room. So for people from Mexico, for example, they value respect. And so, older adults using Mr. or Mrs. When you getting them from the waiting room. So things like that could be helpful in our visits with people, I highly recommend that uh, website. It helped me personally. I had a patient, a gentleman from Iraq, and so I, did some research about Iraq before, and that really helped inform my questions, and it helped me find that actually this person had a trauma history because of the war that they had been exposed to. And so, again, having some working knowledge of the culture will inform the questions that you ask. So that's a good first step.
Mhm. Another thing when working with people from bilingual backgrounds or even people who don't speak English is you want to use the chart to kind of go over the medical history, but you don't want to over rely on that either. You do want to confirm with the patient that you have the right information and you want to still get a pretty throughout kind of medical background from them because kind of things get lost in translation sometimes with the use of interpreters. And really, as bilingual providers, we have a really unique opportunity to not have those language barriers and to really clarify a lot of things for other providers, right, in the medical chart as well. So one of the things that you want to really make sure that you talk to patients about is seizure history and semiology. So you want to go step by step with the patient. Preferably, you want a family member or a trusted individual with them that can provide more information on this because sometimes patients aren't aware of a lot of these behaviors. So you want to know about seizure onset, right? How long have you been having seizures? When was your first seizure? How frequently are you having seizures now? How frequently you were having seizures before when you first started having seizures? Is there a pattern to your seizures? Are there any triggers? Is it when you're sleepy? Is it when you eat too much sugar? Is there a time of the day? A lot of seizures happen at night, all right? You want to know that because that's all information that's going to help you clarify location, right? And that's one of our jobs. You want to know about how long the seizures are. Specifically, you want to know if there's a status epilepticus involved, right? Have you been seizing for more than 5 minutes? Have you had any complications with prolonged seizure activity? That's important from a cognitive perspective. You want to know the symptoms of the seizure starting from the beginning. Do you have an aura, right? How do you know a seizure is coming? Do you have a metal taste in your mouth, perhaps? A sudden rush of anxiety? That's all information that can help us localize seizure onset. What happens when you're actually having the seizure? What happens before? Are you tired? Are you confused? For how long are you tired and confused, right? Have you had any injuries related to your seizures, whether that's a head injury because of a fall? We want to know all of that. Your last seizure, of course, you want to know if they had a seizure that morning that can impact test results, for example. So all of this information is important for you to ask about. You also want to ask about developmental history, right? You want to know these person's history since the start. Were there any complications with your mom's pregnancy, your birth, right? Any developmental delays that can also help us establish a baseline. How does your development look like, right? Do we need to be considered doing things like perhaps borderline intellectual functioning? Do we need to be considering baseline learning disability, right? We don't know about those things unless we ask. And of course, you want to get all of the normal psychosocial history, things like education, work history, drug use, language, mental health history. So one of the frameworks that could really be helpful is this eclectic framework. You can find more information in that paper that I cited there. So this framework really gives you an idea of what are some of the things that are important when you're evaluating a person that's not from this culture. Um, things like education and literacy, right? You want to know about their education quality as well. That's just going to inform how you provide medical information to them, in what language you provide that information. You also can report back to the surgical team, how is this person going to learn better? You want to know about their culture. Is there any stress related to acculturation issues? You want to know about their language, and we're going to talk about this a little bit more in the next slide. Economics, right? Are your basic needs being met, right? Do you have food security, home security? Are there any socioeconomic factors that might impact your access to information, that might impact your ability to follow up in treatment recommendations, right? How do you communicate better? How familiar are you with the testing situation? This is going to be really important for us, right? Because a lot of people don't really are used to standardized testing, right? That's a very us thing that we do a lot. Not a lot of countries do that. So you want to know what their experience is, because this can be a very anxiety producing experience for someone who doesn't have uh, any kind of background on what this looks like, right? It can be really weird for someone to be presented with tests like this. And this is important because you want to create a supportive atmosphere. You want to address any anxiety that might happen, right? You want to know about how they conceptualize intelligence. Not everyone thinks intelligence is the same thing, right? The context of immigration, like Dr. Miranda was talking about, right? Is there anything about your immigration that it's impacting you right now, right?
Yeah, and so as Dr. Rivera Figueroa mentioned, language is one of the really important things that we have to assess for when we're doing these evaluations. And so when we're doing this, first what we have to do is we have to obtain a language profile on each language that the patient speaks fluently. What we're trying to do is we're trying to assess for what the primary language is, because that's the language that we would perform the neuropsychological evaluation in. And so we would ask a lot of questions. This specific component here, language, is there's a lot of information here, a lot of things that we need to cover, and how do you do a language profile for each language? This is going to be would be its own presentation, but I will say we will be talking about this in further detail. We're doing a talk with the Colorado Neuropsychological Society, and so if you're interested in this particular topic, we'll be discussing it there on October 24th. But what I will say is that people who are bilingual or multilingual, as what you want to assess for, again, is that primary language. And so what you can do is you can ask questions such as, what language do you use to think or dream in? So people who are very fluent or very proficient in two or more languages do have the capacity to think or dream in more than one language. But generally, people have a dominant primary language that they do this in. These more automatic functions that happen will be done mostly in that primary language. That's why you want to ask these questions. But for people who are very highly bilingual or multilingual, they can still perform these functions in the various languages that they speak in. So in that case, you're going to need some objective testing to really assess which is the primary language. And the way that we do this in our clinical practice is we use a naming test and a verbal fluency test, and we do both of those tests in both languages, or however many languages that the patient is actually fluent in, to get a more objective sense of what is the primary language for them. And that's the language that we'll be doing testing in.
So the other thing, like Dr. Miranda was saying, we are really fortunate in that we get a lot of time with these patients. So one of the things that we can really contribute is this psychosocial aspect, right? Medical providers don't usually have this information, and we can provide a lot of good information about psychosocial adjustment. So really, you want strong psychosocial adjustment because this is what's going to be linked to better surgical outcomes, right? So we need to be able to identify potential barriers to surgery. We want to help patients develop realistic expectations for surgery. We want to be able to recognize and address non-cognitive factors that can impact care in addition to cognitive factors, right? And you want to share all of this insight with the surgical team so you can ensure a supported environment for this person post-surgery. So some areas to focus on. So you want to know how the seizures is impacting this person's day-to-day life, right? Is it impacting your work? Is it impacting your driving? Is any of these impacts causing you to feel anxious and depressed? Um, you want to assess emotional well-being. So you do want to be screening for things like anxiety and depression and even other less common psychological disorders as well. We know that there's a very clear relationship between epilepsy and increased rates of anxiety and depression. So for instance, up to 58% of children who have complicated epilepsy can experience mental health issues. So really, this is a pretty core factor in the epilepsy experience. So we do want to make sure that we are addressing those things. You also want to assess how ready are they for surgical challenges, right? What are your coping mechanisms? Like, are there any positive coping mechanisms that we can enhance? Are there any maladaptive things that you're doing that we need to minimize? Things like drug and alcohol, for example. How does your surgical support look like? When you undergo surgery, you are going to need a lot of help. You're going to need a lot of social support. So we want to make sure that this person has the appropriate support and the appropriate help post-surgery, but we also want to address, are there any issues in their social dynamics currently, right? So we had a patient not long ago who came in for a pre-surgical evaluation. And when we were doing this process of gathering this information, we found out that she was actually on a very a domestic violence situation, right? She had a kid in the house. We had to ensure that the kid was safe. She also had recently undergone surgery, was severely depressed, could not really engage in the testing procedure the first day. And these are things you want to know because at that moment, what was important for her is, are you connected to a social worker? How can we get you these supports that you need to ensure that you're safe? And then now surgery gets to the bottom of that, right? We need to ensure safety first. So these are the things that you want to know about, and you won't know about it unless you ask, right? And then sorry, Dr. Miranda, you were going to say something?
Well, I was just, yeah. So just, you want to know again about the whole being, this whole being, and any part of their life that could impact this surgical process for them. And sometimes for some people, there are other needs that come before this surgical process, some basic needs like safety, and food, and home security. And so it's important to ask about as much as possible of their life. You want to know about all of them so that you can really support them.
And then there's also cultural considerations, and this could be kind of, beliefs about health, beliefs about surgery, beliefs about medication. But it could also be like stigma, right? Or attitude towards medications. So these things are also important because it can impact treatment adherence, right? If you have any negative beliefs about medication, it can impact your willingness to share your experience with other people and therefore impact um, your different like things like work and school, so people can't really support you if they don't know, right? So you want to also know about these things.
And for this, for education and advocacy, I do think it's very important that we take the time to provide some education to patients, because what we want to do is we want to empower them with knowledge, so that they can really take their rightful place in the treatment team. They are a part of the treatment team as well, and they have a lot of information that we do not have. And so sometimes even just giving them the vocabulary to be able to discuss these things with providers can be so helpful. And I usually will ask patients about, well, how much do you know about seizures? How much do you know about epilepsy? And really just having conversations around that so that I can provide some information about that, providing information about these cognitive impacts of seizures, the psychiatric behavioral concerns that can arise, even school and employment, thinking about, do you have a seizure action plan in case of an emergency? If you have a seizure outside in public, do you have a plan for what would happen? Again, talking about the stigma, if you're not comfortable sharing this with your workplace, maybe they might not know what to do. And then you have a seizure at work, and then they call 911, and then you're taken to the ER and you have to pay for that bill. But maybe if they know about it and there's an action plan, then maybe things can happen a little bit differently. And so really arming patients with education and resources to help them have some plans in place, and really, again, helping the treatment team by providing us the information that could be really useful. And then again, if there are any learning disabilities, long-term planning for seizures and epilepsy, and then providing some support groups could be really helpful for patients. And then really advocating for them in the treatment team is providing this information to the treatment team that could be helpful. For example, someone has a low educational attainment, maybe they have some reading deficits, a reading disability, and really making sure that the treatment team knows about this. So whenever they're provided with written material that is either simplified, or if there's an alternative way of providing information, such as a consent form even, making sure that we're thinking about all of these things that could affect the patient, and how we provide information to them so that they can really understand the information.
So one of the roles that we have too, of course, is it's cognitive, right? So we've talked about all of the other roles that we are usually less familiar with, but we also have some the role of just providing a baseline, right? So we want to get a clear picture of where the patient is, right? We want to establish a baseline. We want to know their weaknesses, what are their strengths. We want to identify any deficits that could be related to epilepsy. And then we also want to look at kind of all of the domains, right? So we are specifically interested in memory, both visual, verbal memory, language, visual spatial abilities, executive functioning, motor abilities. Having information about all of these domains is going to be helpful when we think about lateralization and localization, which is what we're going to talk about later on, right? You also want to make sure that this first pre-surgical evaluation, it's comprehensive, because this is going to be the baseline for future comparison, right? We usually do this twice. We do this before surgery. How are you looking right now? And then we do this after surgery. So what are we seeing now, right? After you have undergone surgery. And we also want to get an idea of cognitive reserve, right? Is this person going to be able to compensate for damage? Are they going to be able to maintain function despite these impairments? And it kind of helps us predict recovery, right? So generally, when patients have a higher cognitive reserve, they're more likely to regain some of those abilities post-surgery, right? So that this baseline, it's really important for all of those reasons.
And in talking about lateralization, localization. So first, what we want to do is ask about handedness. That gives us some information about where their verbal and visual abilities might be. Generally speaking, the kind of more conservative numbers have been about 98% of people who are right-handed have their verbal abilities in the left hemisphere. And then if you're left-handed, it drops down to about 50% that you might have your verbal abilities in the left hemisphere. But then there's that other 50% where you might be have your verbal abilities on the right side, or you might have a mixed kind of organization of language. So it's important to ask about handedness. But then what we want to do is when we look at the data, we want to see, are there more deficits in visual material versus verbal material? Because that'll give us information about which hemisphere there are more impairments are in. And then are we able to really localize, meaning can we get to which lobe is not working properly? So can we get to like a left frontal lobe problem, impairments here? So that's kind of what we want to do, is we want to see, really look at the data and look at where the deficits are, and that'll give us information about lateralization and localization.
All right. So as psychologists, we rely on cognitive data to make some of these assumptions, right? So, but there's also more objective ways of identifying function. So some of these are listed here. I'm not going to go into a lot of detail on any of these because, again, we have a prior talk that really goes into a lot of detail on this, but really important things here. So the important of functional mapping and us as neuropsychologists to be part of those processes is that we really want to identify key brain functions because we want to preserve tissue that is functioning well, right? We want to be as less invasive as we can when we go into that surgery. And it's also important from a multicultural perspective because these tests really need to be done in the languages that the person is fluent in. So if you have a Spanish speaking patient, this should be done in Spanish, right? If you have a bilingual patient, this actually should be done in both languages because languages can actually localize to different regions, and you want to make sure that you're mapping everything correctly because you want to preserve function in both languages, right? So really that's the key part here from a cultural perspective. So the other thing that neuropsychologists offer is we're good at making, well, we think we're good, perhaps we're not, at making predictions about how cognitive functions will be impacted post-surgery, right? So we really want to make sure that we understand those cognitive costs, right? So cognitive costs refer to expected declines in cognitive function as a result of surgery. So cognitive costs are often seen as inherent risk associated with the surgical process. So you want to make sure that you understand what those are and that you can communicate that to patients so that they can make an informed decision about these. There's also cognitive contraindications. These are the no-nos, right? So is there anything any risks that are contraindicated that would actually mean this person should not have surgery, right? So these are considered unacceptable outcomes. So things like severe memory loss or significant language difficulties, right? So we want to identify those as well. And then we want to understand the cognitive complications, right? So these are unexpected cognitive changes that may arise from either unrecognized preoperative factors or perioperative issues, things like difficulties with anesthesia. So we are a lot less, uh, I guess, good in predicting things that could go wrong with surgery, but it is important that we know as provider that these things can happen and that you're communicating those potential risks that may happen to patients as well.
Yeah, and there's some great tools that we can use to really to give patients information about how much cognitive decline could be possible. So there is a nomogram that we can use that it is a really fantastic tool to give us some percentages about the decline that could be possible in naming, in memory, or even in mood. And so this is a really helpful tool. However, as with any of our neuropsychological tests, we need to be looking at what the group that was used as a reference population for creating the nomogram calculator, and who was used to validate these measures. And so anyone that is not part of that group, this is not necessarily something that could be really useful in any group outside of that the group that it was valid on. What do we do then with patients who are outside of these groups? And so we have to really think about, what is the functional reserve that they might have and that contralateral hemisphere? What does the memory look like there? What is their functioning in the functional adequacy in the ipsilateral hemisphere? Because if let's say the seizures are coming from the left side, the left hemisphere, that left temporal lobe, and their memory is bad for verbal material. But then what about that other side? So if there's going to be a resection in that left medial temporal lobe, and there's a risk, of some cognitive decline, they're already functioning poorly, but can the other side be a good reserve to help them? Or is there a risk for some global amnesia? And those are things that we have to consider, but we know, so maybe if there's poor functional adequacy, then maybe there's a less risk for this patient to notice a bigger cognitive decline after surgery. And so these are conversations that we'll have to have with patients, but it's something that has to be tailored to the patient. And not all patients will have experience cognitive decline after surgery. And this could be for many reasons: seizure focus, maybe the type of surgery that was provided. But we also have to think about the ecological validity of our own tests. What are we really testing here, and how does this apply to everyday life? So just things to consider. And then, of course, these post-surgical outcomes to consider for based on age, duration of their epilepsy, medications that they're using, their seizure control, the seizure frequency, and really the extent of the surgery. So all of these things play a role in the possibility of decline after surgery.
So one thing that really helped me when I was learning about kind of functional reserve and functional adequacy, I think about it as like, all right, so from how tall am I falling, right? So if I have really great verbal memory and they're targeting my left middle temporal structures, I'm going to be falling from a really high place. So I am going to really hurt, right? When I hit the ground, it's going to be like, ouch, this something happened, right? But if, on the other hand, that tissue, it's really serving not no purpose, I am actually going to be falling from not that high. So if I fall a little bit, it's going to be like I might scratch myself, but I'm not going to notice anything that's really going to impact me on my day to day, right? So when it comes to this, we actually want to see that that tissue is not functioning, because then that lowers the risk of this person falling and really like breaking a bone or something. That helped me kind of think about these things. So, just future directions here. So, we talked about our role in providing information, laterally, predicting cognitive risks. One of really, as neuropsychologists, one big role is really like, can we improve functioning? And when can we start intervening so that we can improve outcomes? So there's two terms that are really understudied right now that we think that this, kind of as a field, we really need to start studying more about these things, because that's really an important role of ours as neuropsychologists. And so one of them is pre-habilitation. So this refers to, is there anything that we could be doing right now pre-surgery to ensure that you are prepared for potential cognitive deficits later on, right? Is there any treatment that or intervention that can help improve cognitive outcomes? Because I think that's important in terms of preparing people for surgery. And then there's the term of cognitive rehabilitation, which we're more familiar with, is post-surgery. Is there any interventions that can help improve cognitive functioning on their day-to-day life? Things like speech and language therapy or cognitive rehabilitation therapy and things like that. But these, in the context of epilepsy, are both things that are pretty understudied right now, and there's a push for us kind of learning more about these things and kind of more empirically supported interventions that we could be using both pre and post surgeries to improve outcomes, and not only cognitive outcomes, but again, all outcomes, whether that's mental health, psychosocial adjustment, all of that. And as neuropsychologists, I think we should really be thinking about these things.
So in terms of how, again, we're part of a treatment team, and we work with our medical colleagues, our surgical colleagues also. So how do you present this information at surgical conferences? And so I want to offer some options of how to do this. So if we go on here, these next slide, this is an example of how I was taught to do this in my can we go out to the next slide? Again, for surgical conferences, our medical colleagues present the information they have. And this is a chance for us to present any pertinent information about patients. And so this is how I kind of was trained to do this in my fellowship. So these are slides from my supervisor, Dr. Gustavo Rey from University of Miami. So where we would present the patient, name of the patient, education and employment, and then you go on and you present data from the neuropsych profile. And so here what we would do is we would have all the visual tests in the yellow, so it's the non-dominant hemisphere, and then the verbal test in the blue for the dominant hemisphere. And then we kind of we provide this visual for our colleagues of any potential lateralization. And so here we see a drop in learning and memory of visual material. So there's some lateralization that's happening here. There's a trend here. And so if we go on to the next slide, then we have more information about executive functioning and processing speed. And then next slide, here we talk about this key point. So their cognitive abilities, what their IQ level is, any premorbid estimates that we can make. What does that cognitive profile look like? And then any lateralization or localization. We talk about the psychological piece, any psychiatric disorders. In here, in this example, the patient talks about stressors due to their marriage. And we see in the social piece that this particular person, their wife lived in Nicaragua. And so some of the distress that was happening over the marriage was because of the long distance. And why is this important to share with the surgical team? And that's because there's a potential possibility that this patient could be moving to Nicaragua because of this, the marital discord that was happening. And these are things that are important to consider and let the surgical team know. If we go on to the next slide, so I since updated the slides, but I've had colleagues update them further. So these slides are courtesy of my colleague, Dr. Chris Doman, who created these slides. And this, again, name of patient, and we give all the information up front here, you know, their education, employment, history, any psych history that's relevant, including substance use, and that social background here. And then if we go on, we look at the neuropsychological profile where we have that lateralization or localization up front, and then IQ level. And then here we use more descriptors to talk about where they are in terms of their language abilities, visual, spatial, verbal or visual learning and memory. And so here you see that there's a drop in language abilities and verbal learning and memory. And then their visual, spatial abilities, visual learning and memory is actually intact. And so here we're seeing some clear lateralization because even with motor, the right hand was worse than the left hand. And so this is all pretty much consistent here. So this is just a way of offering you how to discuss this, our results and what we're finding in our evaluations with surgical teams. And then we're kind of running short on time here, but we wanted to briefly have an example of a case study for you so that we can put all of this together. So if we go on here, we're going to look at the sample patient. And so we'll look at, so let's do all the first column. Okay, so here. So we have so this is information from the medical record. So you're preparing to see a patient, and this is the information that you have available to you. So this is a 25-year-old female. She had the one episode of syncope in 2018, but had her first convulsive seizure in 2022, where she was diagnosed with epilepsy. And then the onset starts with some anxiety and hand tingling. She has a bad taste, a smell, and then some speech arrest, loss of awareness with automatisms. Rarely has convulsions. And so the theory here is this focal left temporal versus an insular onset for this patient. MRI revealed that there was an arachnoid cyst with mass effect on the left temporal lobe. The routine EEG was normal. She was on Keppra, but was having some mood side effects. And then they were going to add lamotrigine. So the other part of this, she works as a teacher, so they wanted to start their surgical workup in the summer. So I wanted to ask about what questions you would all have so you have this patient presented to you. This is the information you have. What kind of questions would you ask during the interview process? So Dr. Rivera Figueroa, you and I will get started because we're running short on time, so we're going to have to speed this up a little bit.
Okay. Do we know? So she's a teacher. What's her first language?
So that's a good question because she's actually bilingual. So she actually spoke Spanish also. And it turns out that was her first language.
How bilingual though?
So she actually says that she's fluent in both. And that she basically
Hmm.
can um, think and dream in both languages.
Oh, she's making this hard. Anyone else has questions? No? Okay. Um, so what language does she prefer though?
So she doesn't really have a preference on language.
Oh, so do we need to test her objectively then?
Yes.
Oh, okay.
Yeah, so she speaks English and Spanish at both work and at home. So she's a teacher. And actually it it was a way for her to compensate. So she is having some word finding problems and she uses both languages. When she can't think of the word in one language, she'll use the other language to compensate.
And what has objective testing told us?
So we're gonna do some naming because we're culturally sensitive neuropsychologists. And we're gonna do some naming, testing, and verbal fluency testing in both languages. We're gonna norm it. We're gonna take a look at what the data looks like. And actually for her, she did not do well in naming in both languages.
Mm.
But she did pretty well with verbal fluency in both languages. So basically, this is someone who is very highly bilingual. She's very proficient in both languages. Um,
Doctors Miranda and Rivera Figueroa, we have a few comments from the chat. Uh,
Great.
they would like to know, what language did she do her education? What language does she use for her job? And what is her handedness?
oh, love it. Okay, so hold on. You're gonna have to tell me that one by one because I already. Okay,
Yes.
so
So,
language at
So the
work.
first was, in what language did she do her education?
So she did her education in English. So she's actually that's where she learned English was in kindergarten. She learned English, and then all of her schooling was in English.
And what language does she use for work?
At work, she uses both, but predominantly teaches in English. And then at home, uses both languages.
And finally, what's her handedness?
She's right-handed.
I think
good.
those are all our participation questions from the chat for now. Thank you.
Okay. Those are good questions.
So what do we do? So it sounds like she is pretty much fully bilingual. There is pretty much the same performance both in English and Spanish. So how do you solve that issue?
Yeah. So what I did was I tested her in Spanish because the norms there, I think, are a little bit more forgiving, but also like I think they would show us a more clearer picture of
Mhm.
her current functioning. So she was actually tested in Spanish.
Mhm.
All of her testing was in Spanish. And I'll show you the results here in a little bit. The other parts that I wanted to touch on were that she, from her psychosocial history, yeah, you can, because we're running short on time here, but she was adopted actually. So she didn't have a lot of history, developmental history. She didn't know. But her parents, her adopted parents are from Mexico and they only spoke Spanish. So that's why she grew up speaking Spanish. She did have some challenges in reading and writing in English that really persisted to college. And she received some academic support for that. She actually had to take her language tests to work as a teacher 8 times before passing. So she really struggled. But at that time, she was also having seizures. So it's unclear, what was causing that issue for her.
Mhm.
Again, speaks both language fluently in all parts of her life. 16 years of education, She works as a history teacher in middle school, and there was no other mental health history or substance use. So when we look at the neuropsych data, so what I did was, because I tested her in Spanish, I use these Spanish measures. And so I use, you'll see here. So what I'm showing you here, so on the left side are her verbal abilities and the right side are her visual abilities. And I just wanted to put them side by side so you can see if there's any lateralization. But really the only area, this is so small, but I hope you can see it, that really the only area of deficit was that naming. This is the Spanish test. This was all in Spanish. I use the WACE for Spanish. There's a Mexico version. There's also a Spain version, but I use the Mexico version for this patient. And then I use the BNE, which is the Batería Neuropsicológica en Español. And I use a test from there. So I use the logical memory from there. The phonemic fluency from there. And then I use the MAMI. This is the kind of the Spanish version of the Rayvault for this. And then the BVMT as the visual measure. And so you'll see here, basically, she did relatively well on learning and memory of verbal and visual material relatively well. Some, minor fluctuations here and there. But again, that mostly the area of impairment was that naming area, and that was impaired in both English and Spanish. It's kind of a very focal. So this is a little bit more localized information that we have here. And so this information allows us to go back to the surgical team and say, look, this is someone that is very highly bilingual in both languages, and she's having the same deficits in both languages. Any tests from here on out, should be in both languages for her. They were thinking about doing a left ATL for her, a resection. And so language mapping was a recommendation here in both languages, which is very important for her.
Mhm.
And that's the, the fast version of this. Any questions? Okay, so I wanted to share some resources that I think are really important for patients. The Epilepsy Foundation is fantastic. They have a lot of different resources. I love this 24/7 helpline that they have. I share it with all of my patients in case they need almost anything to call this helpline. But for us specifically, they also offer kind of a first aid seizure training. And I do think it's important, if you're going to work with people who have seizures, it's good to know what to do in case they do have a seizure. I also recommend that family members take this training, the certification, so that they know what to do. So the Epilepsy Foundation is a really great resource. International League Against Epilepsy is also a great resources. They have a lot of great information on their website. But one of the things that they offer also is every 2 years, they offer a training. And it's actually somewhere in Europe. It's fabulous if you want to go, and if you guys have like travel funds. It's a week-long intensive training, and they talk about neuropsychology and epilepsy. So it's wonderful. I highly recommend that. And then a book for some more information by Dr. Greg Lee here. But there are a lot of other books and articles that are really great on this topic. So if you're interested in learning about all of them, we are happy to share all of those with you. So feel free to get in touch.
Muchas gracias a todos por.
Thank
All
you
right.
all. Thank you both very much for this presentation. I've been getting several comments on the side here about how wonderful this was and how helpful it was. I I realize that we're over time, so if folks need to hop off, that is okay. But if you don't mind, we do have a couple of questions if you guys can spare the time. Wonderful. Okay. So first, we know that the assessments that we use now are not always the best and may not best reflect our patient populations. So could you both please share a little bit of insight into how to ensure that these assessment tools that we're using are culturally sensitive, make sure that they're appropriate? Yeah.
Yeah, so I think about this all the time. But really, so they're just unfortunately, our assessments are just not great all the time. And
Hmm.
when they are used with like population groups that are outside of the reference population, there of course there are a lot of validity issues and concerns, right? But I do still think, well, so first of all, again, our measures are generally speaking a more Western-based tools, right? They have kind of the Western population is kind of seen as the gold standard
Hmm.
for these measures, and so we have to keep that in the back of our minds when we're using these tests. But I still think that they serve a purpose, and I think that it's really good to still even just see the patient attempt to do these tests. So behavioral observations are, I think, something that we have to fall back on
Hmm.
when the validity of the test is in question, and the interview portion. So the
Hmm.
interview portion where we collect as much historical information as possible and observations are key. So we have to fall back on other skill sets that we have as
Hmm.
neuropsychologists. And sometimes just that, like being able to watch them try to attempt to do these tests gives us a lot of great information. I hope I answered that.
Yeah, and in terms of you really like Dr. Miranda said, it's flawed, but there are norms out there. So you just want to make sure that you are using tests that you have some normative base for them so you can really compare, and you want these norms to be not only language pertinent, right? Not all Spanish, for example, speaking patients are created equal, so you want them to be specific to their nationality as well. So we usually use kind of some norms for Mexican and then some other norms for other groups.
Yeah, and I will say, so to that point, so it is possible to still do this, right, with in cross-cultural evaluation. So you do have to find tests that are appropriate for that specific population and norms. And I would say that to do this under consultation also, we do have providers in the field that have knowledge about different groups and different cultures. So for example, I just did an evaluation for a gentleman who speaks Mandarin. And I actually contacted some colleagues of mine to consult about that. And they guided me through that process. And so using our colleagues, using uh, professional organizations such as HNS, ANA, SBN, um, those organizations, you can find colleagues that are willing to consult to help guide you through these evaluations.
Thank you. And we have one more also, which you both kind of alluded to in your answers here. So we wanted to know if you had any suggestions for monolingual neuropsychologists or trainees who might not be comfortable assessing in a second language yet. And do you think these assessments can still be adequately provided with the help of an interpreter? And where do they fit in?
So yes, I do think that it is possible, right? Again, especially under consultation and looking for the appropriate tests and appropriate norms. These evaluations are possible. The other thing that I will say is that it also depends on the quality of your interpreter. It is possible to do this with an interpreter. I would say It does require meeting with them beforehand to get them trained and making sure that they are going to be able to help you through this process. If you get a really good interpreter, it can work really well because the interpreter then can even serve as the cultural liaison
Mhm.
in the room with you. So it can work really well. And sometimes you get some interpreters that have a little bit more difficulty and require a little bit more work. And so, even when there's a lot of questioning about the validity of the evaluation, that you can still get some good data based on other things. So maybe the numbers are not super helpful, but your observations and the history is still going to be really helpful.
Wonderful. Well, thank you both very much. I think that does it for our questions. So I'll just remind everybody to please join us again next week at 4 p.m., so an hour earlier, for cognitive prehabilitation and rehabilitation in neurosurgical populations with Dr. Kayla Arota. Thank you all very much, and we'll see you all next week.
Thank you.
Bye.